Hello. Today we'll talk about principles of therapy of Bartonellosis. So this is typically an introductory presentation, and if this presentation will be successful, down the road we'll talk about more advanced therapy. So in general, we can divide therapy for Bartonellosis in several clusters. The first and the most important, which we're going to discuss today, is antimicrobial therapy. Also because Bartonellosis quite frequently is associated with autoimmune diseases. At some point we'll talk about treatment of its autoimmune complications. Treatment of metabolic and endocrine complications also is an important topic in the therapy, and it will be a part of more advanced course. And the same is as therapy for dysautonomia, mast cell activation syndrome, and neuropsychiatric problems. So what are the goals of antimicrobial therapy? So the goals are very similar to the goals of therapy for any chronic infections, whether it's TB, whether it's Bartonella infection, whether it's mycoplasma infection or chronic hirsusiosis. So first of all, you need to reduce the pool of Bartonella and reduce the total Bartonella count in the body. The second goal, which tightly connected with the first one, is you have to induce Bartonella dormant state, where microorganisms are minimally metabolically active, and then you have to maintain of this dormant state. So very straightforward. So when we're talking about antimicrobial therapy for Bartonella, we typically divide it in 4 different sections. So therapy for acute Bartonellosis. Honestly speaking, we don't see in our clinic too many cases of acute Bartonellosis, and I'll present the data which I compiled from the CDC website. Antibiotics for chronic Bartonellosis, that's what typically we're dealing with in our practice, as well as botanicals and nutraceuticals, which is an obvious part of therapy for this chronic infection. So this is basically a paragraph which I compiled from the CDC website, and it talks about antibiotic therapy for acute Bartonellosis. So what you can read, that the use of antibiotics typically is done to shorten the course of the disease, and based on CDC recommendations is highly debatable option. I don't know what to debate, because if you don't treat it aggressively enough, you'll enter straightforward the chronic phase. So there's nothing to debate. Most cases of cascade disease, based on CDC recommendations, resolve without treatment, although some patients may develop complications from disseminated disease. Is this true? Yes, on a short-term basis, but down the road they'll present with complications and will be dealing with major issues related to chronic Bartonellosis 5 years down the road. So azithromycin has been shown to decrease lymph node volume and more rapidly compared to no treatment. Completely agree. And then CDC basically presents the recommended dose for adults and children, which we're not going to argue about. And then the final paragraph, which you can find on the CDC website, is that a number of other antibiotics are effective, including penicillins, tetracyclines, cephalosporins, and aminoglycosides. And the final sentence is, since aminoglycosides are bactericidal, they're typically used as a first-line treatment for Bartonella infection, other than cascade disease. Often with serious infections, more than one antibiotic is used. Is that a true statement? Yes and no, and we'll talk about that in a few seconds. So, sorry about that. So this is just basically an educational table I compiled from regarded article, and it talks about a minimal inhibitory concentration for various Bartonella species determined by a guard dilution technique, meaning that it's done in vitro. And as you can see, macrolides are very actually active against Bartonella species, as well as aminoglycosides, cephalosporins, and penicillin. And this is the second part of the same table, which show that quinolones, tetracycline, and various other antibiotics can be used. So special attention should be actually focused on rifampin, which is a part of standard therapy for chronic Bartonellosis. So, but now, where is discrepancy? Well, Bartonella species are highly susceptible to beta-lactams in vitro, meaning penicillins and cephalosporins. However, this fact has very limited clinical value because bactericidal effect of this group of antibiotics mainly restricted to extracellular bacteria, whereas Bartonella is mainly intracellular and is protected from the activity. So in clinical setting, you can use these antibiotics, but I found that the usefulness is very limited, if any. So another issue is use of fluoroquinolones, such as ciprofloxacin and levaquin. So these are antibiotics that are extremely popular in general practice, and their role in the therapy of acute Bartonella infections remain unclear. We don't use them for patients with chronic Bartonella, first of all, because of number of complications. And the bottom line is that although successful treatment of Bartonella with fluoroquinolones has been reported, there have also been some poor outcomes and relapses with these drugs. So what's been also reported that Bartonella species can easily become resistant to fluoroquinolones, and it has been suggested that in general fluoroquinolones should be avoided for treatment of Bartonella infection. So what do we use in our clinic? What are the mainstream antibiotics to treat chronic Bartonellosis? So first of all, it's azithromycin and clarithromycin, both macrolides, and you need to make your own decision which one you want to use, depending on the patient situation. Doxycycline and minocycline are very useful, as well as rifampin. And actually, we're using it as a standard combination. Typically, we combine one of the macrolide with one of the tetracycline and either rifampin and rifabutin. And typically, when we're using azithromycin, I like to combine azithromycin with hydroxychloroquine or Plaquenil. The question is why? Well, it's been shown that hydroxychloroquine increases intracellular pH, and it makes azithromycin much more efficient, and that's why it's one of our standard combination. You don't have to use full dose of hydroxychloroquine, which is around 200 to 400 milligram a day. You can get away with lower dose, such as 100 milligram a day, and it'll be sufficient in most of the cases to alkaline the lysosome of the targeted cells. So also I want to mention that once in a while we're using orphan antibiotics. So you'll be surprised, but nitrofurantoin, an antibiotic frequently used to treat a urinary tract infection, is very active against Bartonella. However, the question mark is what is appropriate duration of the therapy, and we don't have the answer right now. Sometimes we're using daptomycin for the therapy of Bartonella, as well as a short course of ivermectin and chloroquine. All these antibiotics were published to be efficient against various Bartonella species. So in addition to antibiotics, we're frequently using botanicals. And this is a list of botanicals which we use in our practice. So they include Oncaria tomentosa, which is a cat's claw, Toba parviflora, Lomatium dissectum, Scutellaria bacalensis, olive leaf extract, and Campesandra. In addition, lately we start using more and more Juglans nigra, which is black walnut, Polygonum cuspidatum, which is Japanese knotweed, Cryptolepis sanguinolenta, which is very toxic but can be used in short cycles, Artemisia annua, Chinus terebinthifolia, and Chinus molla, which are Peruvian and Brazilian peppers. And you can use them as a combo, and at the end of our presentation we'll talk about a case study, and I'll show you exactly how we use some of these combinations. So last year there was a good article published by a group of basic researchers, and the article is talking about activity of several botanicals against stationary phase of Bartonella hansel. And so this is the table which I compiled from the article. As you can see, there are several herbs with very good combination, very good MIC against Bartonella, including black walnut hulls, Japanese knotweed, Cryptolepis, and also Scutellaria. And these are the herbs which you can use in your practice. I would caution you about using Cryptolepis because of potential side effects. And same article actually showed a very nice graph with inhibitor concentration of various herbs compared to antibiotics. What you can see that, again, the inhibitory activity is kind of similar during the initial time presentation, let's say 24 hours, with the exception of rifampin, which is found to be much more active than the rest of the group. But by day 5 or 7, the activity of herbs was superior to the activity of antibiotics. Again, remember, this is in vitro data, and not necessarily it can be converted in the everyday clinical practice. So be cautious with the interpretation of these results. So we also frequently use certain nutraceuticals. So again, this is a list of the most common nutraceuticals in our practice. It includes myoinositol, D-chiroinositol, definitely L-arginine, and L-arginine derivatives such as, for example, agmatine. We're using more and more vanadyl sulfate, which has unique activity against Bartonella hansel. And also frequently we're using organic germanium, or GE132, to stimulate production of hydrogen peroxide in macrophages and kill intracellular microorganisms. So in this slide I also mentioned some nutraceuticals which kind of between nutraceuticals and botanicals because they have plant origin. But I call them nutraceuticals because they have defined chemical nature. So first of all, these include berberine, cinnamomine, bicolin, which is an active ingredient from Scutellaria bacalensis, luteolin, bromelain, and CBD. So several years ago, actually around 2008, 12 or 13 years ago, there was an article which showed that L-arginine can interfere with the specific pathogenic steps in Bartonella infection, and I think that this is a very important supplement. Unfortunately, L-arginine is not very well tolerated because a lot of patients develop profound hypertension, but for those who can tolerate, it's a good supplement to use. So let's talk about real life. This is a case presentation. So 62-year-old woman with complaints of tingling and numbness in hands and feet, anxiety, palpitations, joint, tendon pain, and mucosal dryness, who presented to our clinic for evaluation and management. And again, this is many hundred cases which we see in our practice, and I decided to pick up the most common presentation to give you some idea what you can see in your practice. So duration of the symptoms prior to consultation was around 2 years. She was seen by 6 or 7 local MDs. and diagnosed with fibromyalgia and depression. She was started on tricyclic antidepressants, but could not tolerate the therapy due to mucosal dryness, so she stopped the drugs. So her past medical, family, and social history were not very remarkable. She stopped most of her medications, and the list of her medication supplements included only multivitamins and fish oil, and she didn't report any particular allergies. Her physical examination was pertinent for skin and mucosal dryness. She had episodic premature ventricular contractions. Upon neurological examination, she had reduced sensory response to light touch or dorsum of both feet. She had mild hypermobility of the wrists and elbows, and tenderness of her shoulders, knees, and ankles. So during initial consultation, we typically do various instrumental tests, and upon ultrasound examination of her glands, we found that her submandibular glands had very strong heterogeneous appearance. That's something which we frequently see in patients with Sjogren's syndrome. Also, examination of her shoulders found multiple microtears and small calcific deposits within supraspinatus and mainly supraspinatus tendon. So subsequently, the patient underwent ANS and QSAR testing and was found to have strong sympathetic dominance and moderate pseudomotor neuropathy. So we did a broad lab screening, and she was found to have positive IgG and IgM antibodies to carbonic anhydrase type 6. Just to remind you that this test is a part of early Sjogren profile, and we found that patients who have positive antibodies to CA6 are most likely dealing with chronic Bartonellosis. So also she had elevated ferritin, she had low copper and low ceruloplasmin, she had low complement component C3 and normal C4, mild elevation of total IgG, borderline elevated rheumatoid factor. Her blood was sent also to Galaxy Lab, and the Galaxy Lab test results show strongly positive immunofluorescence for Bartonella hanseli and Bartonella quintana with titers above 1 to 256. So based on this combination, she was diagnosed with chronic Bartonellosis, contributing to her symptoms. Again, this is most classic presentation of chronic Bartonellosis, which we see in our practice. So her initial therapy incorporated low-dose hydroxychloroquine, which was 100 milligram a day, low-dose doxycycline, which was 50 milligram twice a day, azithromycin 500 milligram a day, myo-inositol, agmatine, and copper glycinate. Typically, after 4 weeks, we introduce antimicrobial herbs, and these are 3 herbs which were introduced in her particular case 4 weeks later. So they included Oncaria tomentosa, Atoba parviflora, and Lamatium dissectum. The patient started experiencing mild Herxheimer reaction after introduction of the herbs, and what is interesting, she did not experience this reaction after introduction of the antibiotics. So she was started on silymarin, which is an extract from milk thistle, and Chinese rhubarb root, and her symptoms within a week went away. So she reported significant symptomatic improvement after 6 months of the therapy. So we decided to continue the same protocol without any changes for a total of 9 months. And by that time, she reported 75 to 80% symptomatic improvement. Also, she reported near complete resolution of peripheral neuropathy and anxiety. So after 9 months, the protocol was partially modified. We introduced low-dose vanadyl sulfate on 1 week on, 3 week off basis. So we're talking about alternating protocols. So patients go on 1 week of vanadyl sulfate and 3 weeks of antibiotics. So this is a protocol which we designed in our clinic, and it worked extremely well for patients who are either poorly responsive to antibiotics or patients who were preparing to get off antibiotics. In 14 months since the beginning of therapy, she reported 90 to 95% symptom improvement. The antibiotics and vanadyl sulfate were tapered off. Currently, she's still taking the botanical and nutraceutical combination. Subjectively, she's minimally symptomatic. Her lab test results showed negative conversion of anti-carbonic anhydrase 6 antibodies. Her Bartonella titers went down to 1 to 64. Her serum copper and ceruloplasmin levels are still below normal or low normal. So in general, we're planning to continue botanicals and nutraceutical for approximately 3 or 4 years. That's the standard duration of the therapy. So this is one of the many cases, as I said, which we see in our practice. This is a standard case. In the future, we're planning to present much more complicated cases and describe more advanced approaches, as well as talk about more detailed therapy for specific autoimmune or metabolic complications of chronic Bartonellosis. So in conclusion, I would like to emphasize that the therapy for chronic Bartonella infection is a highly individualized one. Typically, based on our practice, the antibiotic therapy alone is not sufficient enough to induce remission or dormant state. A combination of botanicals and nutraceutical plus antibiotic represents our preferred direction, and combination of botanicals and nutraceuticals is our preferred direction in the maintenance of remission. Again, you need to explain to your patient that they need to be patient because the therapy is a long-term one, and if they expect to get better, it typically doesn't happen within a few weeks or few months. So they need to be patient. Thank you, and again, thank you for participating in our seminars. Thanks again.